for COPD from chapter 30. Hello, Jack. This includes emphysema and chronic bronchitis. And hi guys, this is the review on COPD from chapter 30. This includes emphysema and chronic bronchitis. Sorry, my internet's a little wacky, so I don't know if this started twice. But basically, emphysema is the loss of lung elasticity and hyperinflation. This causes reduced gas exchange, which leads to a loss of alveolar tissue. And then chronic bronchitis is inflammation of the bronchi and bronchioles, so it affects only the airways, but not the alveoli. So that's the difference between the two. For COPD, the risk factors are going to be mainly smoking. So all of my COPD patients in clinicals have been smokers, but environmental factors can also influence it, and then a genetic predisposition called alpha antitrypsin deficiency. So they can get tested for that. And then asthma is actually also a risk factor. Complications are going to be hypoxemia, acidosis, respiratory infections. Let's see. Dysrhythmias, respiratory failure, cardiac failure. It's also considered life-limiting, so patients can actually live for decades with it, but it's more common in older men. Symptoms can be the orthopenic or tripod position, and then respiratory changes, rapid shallow respirations, abdominal breathing. Usually these patients are going to be thin with low muscle mass and enlarged neck muscles. You'll hear wheezing. They might have asymmetrical chest expansion, decreased fremitus, and then reduced breath sounds. We may also see these patients with a barrel chest, with a dusky appearance. So we also want to look for cyanosis, and then any delayed capillary refill because their perfusion is not as good. For our patients, we also want to check them for any swelling in their feet and ankles because that's a sign of heart failure. As far as labs we want to look at, we should look at their arterial blood gases, pulse ox, sputum samples, their hemoglobin and hematocrit. The reason we want to look at the red blood cells is because if they have polyurethemia, they'll have an increase in red blood cells to compensate for their poor perfusion and gas exchange. We also want to check their serum electrolytes. So they're usually going to have lower phosphate, potassium, calcium, and magnesium. For diagnostic purposes, these patients will generally get an x-ray just to rule out other lung diseases. And then, of course, pulmonary function testing. And then there's a COPD assessment test or tool that we can use. It's scored 0 to 40, and then the lower the score is, the better. The higher the score is, the more likely they have COPD and the more likely it's not being managed well. For these patients, we want to keep them at least 88% for their SpO2, but generally we're going to see them hover between 88 and 92%. That's kind of normal for them. Our priority with these patients is airway maintenance and improved gas exchange. So we want to assess them at least every 2 hours while they're in our care. And we want to teach them diaphragmatic and pursed-lipped breathing. They should be positioned upright, and we need to teach them effective coughing. Teach them to use their accessory muscles to do that. There's actually more information in the book on that, but we want to do oxygen therapy as well. So generally these patients, as the disease progresses, they're going to be on 2 to 4 liters of oxygen per minute through nasal cannula, and then, or they could do a 40% Venturi mask. As far as prescriptions, it's going to be the same prescriptions that we give our asthma patients. So the beta adrenergic agents, and then the cholinergic antagonists, xanthines and corticosteroids and hormones. I went over some of these drugs in the asthma video. So same. It's a gift. It's a gift on our test. So these patients can do exercise conditioning and pulmonary rehab. Basically, we want them to walk. So they can do self-paced walking. Their goal may be to get to they can get to 20 minutes of walking. Even if they're doing just 5 minutes at first, and then they can slowly increase that over time. That's good. We also want to only suction these patients when absolutely necessary, and then also make sure they stay well hydrated. Having them hydrated will thin their secretions, and also they can have a humidifier in their room or use humidified oxygen. That's good. And then another thing they can try is vibratory positive expiratory pressure devices. Basically, it's an inhaler that has a ball in it. It doesn't have any medication, but it's got like a ball in it, and the vibration from inhaling and exhaling it will help loosen up the secretions and get things moving. So there's a picture of that in our book too. As far as surgery, they could do a lung transplant, but that's relatively rare just because of the limited availability of donated organs. And then more common surgical procedure would be a lung reduction, where they actually just take out a chunk of the lower lung, and it gives the patient the ability to have better gas exchange in the upper portions of the lungs, so they're less likely to get, pneumonia and complications like that. As far as interventions, we definitely want to consult with a registered dietitian because dyspnea can affect their appetite. So we want them to avoid dry foods or gas-forming foods, and then they need to have a high-calorie, high-protein diet because their metabolism is sped up because of the body trying to compensate for the lack of gas exchange. So we also want to recommend small frequent meals if they have early satiety, and then we want to help control their anxiety and stress because that can make things worse. We should also teach them energy conservation techniques. So like if they know that they're going to have to take medication and they want to get their meal, maybe they should get their meal and a glass of water in the same trip if they're going to pass their kitchen, blah, blah, blah. A little example of that. And then also we want to teach them pneumonia prevention. So if they are going to be proactive here, then they should have good mouth care. And so we want to control the bacteria in their mouth, also avoiding crowds and stressful situations and avoiding sick people. And then it's really important for them to get vaccinated. So for pneumonia, and we need to get a flu vaccine as well. That's it for COPD. Just real quick review. All right. Thanks, guys.